morning, class. Hope fourth semester is having a wonderful time at the house. I know how difficult it is to stay home, but stay home, stay safe. Okay. Anyways, I missed you guys in the clinics, and now today I'm going to start with shock. It was Dr. Avinash's class, but as he couldn't come, and today is my duty, so I'm starting this, and probably I'll myself complete this topic also. So at the end of the class, I'm going to take your questions on the YouTube. Kindly ask the questions so that it will be useful, and if anything is there, please let me know. Now we'll talk about shock. You should remember, shock is not just going to be useful for you here in second year. Yes, it is a topic of exam question in second year. It is a topic of question in final year. Almost all the three subjects, that is OG Gynae, 4 subjects: OG Gynae, surgery, medicine and pediatrics, to an extent orthopedics also. And then it is important for your entrance. It is also important for your post-graduation. If unless and until you are not planning to do any of the final year subjects like anesthesia, general surgery, OG Gynae, medicine and pediatrics or orthopedics, these are the subjects that you go, if you're not going to choose, probably shock may not be of so much use, but oromaxillary, that is your ENT, also needs shock. So it's not going to spare you anywhere. You have to learn it in detail, and it is ideal that you understand the topic in toto and ask questions. Hopefully I have sufficient quorum to start the class. I know half of you might be just putting on the computer or your YouTube live on and then go have fun, but it's okay. I'm right now not bothered about it. As I'm to take the class, I'll be taking. Shock is the single most cause of death in surgery. You have to remember this one line is an entrance bit. Shock is the single most cause of death in surgery. And how do you define shock? Because most of you must have finished hemodynamics in second year. That's the reason I'm asking you this question. Shock. But how do you define shock? So all the definitions that you must have put on are inadequate. Shock is a sustained reversible state of hypoperfusion and hypovolemia, which becomes irreversible if the obnoxious stimuli is not removed, and will cause a systematic collapse of multiple organs and ultimately death. This is how you should define shock. So, what are the types of shocks that usually we guys know of? We guys know of shock in about 5 different to 6 different forms. Sometimes it is 7 if you take dehydration as a separate topic. But most of them don't take it that way. They put it in hypovolemia. So you have hypovolemic shock, cardiogenic shock, neurogenic shock, shock due to septicemia, shock due to burns, shock due to adrenal insufficiency, and shock due to burns. These are the different types of shocks that usually we should know about. And amongst this, the most important ones are, or more likely you're going to see, is septic shock as well as hypovolemic shock. Hypovolemic shock is the most important. Actually, it is hypovolemic shock that was initially thought as shock, not pertaining to the others. But slowly, as the subject evolved, the rest of them have come into play. Hypovolemia. How do you know? When do you call a patient is in hypovolemic shock, or when do you say a patient is in hypovolemia? When the patient has lost blood when the patient has lost fluid and when the patient has lost both blood as well as fluid. This is what you consider as hypovolemic shock. So, when do you have hypovolemia? When you have a road traffic accident and a major trauma, you will have hypovolemia. It could be an open trauma, a revealed type of trauma, and an unrevealed type of trauma which is bleeding internally. So you cannot gauge what exactly is happening in hypovolemic shock that is concealed. Then you have a lot of diarrhea, dehydration. Diarrhea is dehydration, and then you have the sunstroke. All of these are going to lead to hypovolemic shock. Hypovolemic shock. When do you say the patient is in danger? Or is all the hypovolemic shocks dangerous? No. Some of the hypovolemic shocks are just transient. You can correct them by just giving about 2-point fluid or something like that. But the more danger that comes in is this, when you lose a lot of blood and fluid. Why? How I tell you as we progress in the class. Now you should understand why is hypovolemia important, and how do you stage hypovolemia of this percentage will cause this much damage. So initially 0 to 15% loss of blood, you have hardly any symptoms. It's very transient. Most of the times you will just need about 1.5 liter fluid to correct it, and then if ongoing bleed is there, stop it. Then 15 to 20 or 15 to 30 is mild shock. 30 to 40 is moderate level of shock, and greater than 40% blood loss is severe shock. And what is the most important feature that you're going to see? That we will discuss now. What's going to happen in the next 45 minutes or so. So I'm going to eat your brain for the next 45 minutes, even if you don't like. Now, shock is, we will know that the patient is in hypovolemic shock once he bleeds or he has diarrhea. What is happening here? So, your body is having loss of fluid or loss of blood, that is causing decreased venous return. Decreased venous return. As the venous return is decreasing, your cardiac output decreases. As the cardiac output decreases, you have a moment please. Okay, no, not important. Yes, as the cardiac output decreases, the tissue perfusion decreases. So initially, as the tissue perfusion decreases, what is happening? Your body says the whole of the systems are not receiving enough blood, so let the important organs keep the blood return and blood supply intact, and we will have to compensate. So what are the important organs that are going to compensate, or just think I will not need enough blood now? The first thing that compromises is renal blood flow. There is decreased renal blood flow that will cause decreased GFR, which will invariably cause urine output, decreased urine output. So when you have decreased urine output, how are you going to see? When you lose about 10% of the blood to 15% of the blood loss, urine output does not decrease. Though renal blood flow minimally is decreased, but it won't. It will decrease to about 30 ml in patients who have lost about 15 to 20 ml of 15 to 30% of blood loss, and it will decrease to less than 10 ml in patients with moderate level of loss, that is 30 to 40%, and it's almost anuria in patients who have lost 40% or greater number of blood. So your body stops renal blood flow or decreases renal blood flow. That will in turn cause decreased GFR, and once the GFR decreases, urine output decreases. What are the other systems that will compromise on not taking blood at this part of time? Are the splanchnic vasculature, that is your abdomen, and then your musculoskeletal system. It says right now I'm almost in rest, I'm myself not able to act, so decrease. This is what happens. And what is the state? In initial mild amount of blood loss, the patient is just sweating. He is sweating, his tongue is dry, not coated, it is dry. Then when he's lost a lot of blood, the patient is now in case of confusion. Why does this confusion occur? Confusion occurs because the patient is having increased lactic acidosis. Increased lactic acid because anaerobic circulation starts, metabolism starts taking place, respiration starts taking place as this happens. Once these things happens, then there is a compensatory mechanism that starts or that gets activated by your body. What does it do here? It simply does that. What does it do in compensatory mechanism? In compensatory mechanism, your body will try to stimulate, or it tries to cause more, will want to produce more amount of blood. So it immediately shifts its focus to increasing cardiac output. So that blood is not sufficient, but your body is trying to compensate. So you will have tachycardia. Once the tachycardia sets in and still the amount of blood is not there, so what will happen? Your body has decreased venous return and the lungs are not able to do anything. So your body, as metabolic acidosis sets in, that is lactic acid, increasing lactic acid in the body, will cause metabolic acidosis to set in, and this metabolic acidosis will be compensated by aerobic, that is your lungs. It will start compensating by respiratory alkalosis. So the patient will be having tachypnea. He will be having tachypnea. And as this process the body will have tachypnea, decreased urine output, tachycardia, tachypnea, and then because there is not adequate amount of blood that is being circulated, your blood pressure would fall. These are the compensatory mechanisms that is taking place, and then these compensatory mechanisms do not hold good for a long time. So what will happen? There is further activation of mechanisms that will try to help your body. Number one is your adrenal glands get activated. They will produce what you call as ADH, antidiuretic hormone. Antidiuretic hormone is also called as aldosterone. So it causes sodium and water retention so that the circulating volume increases. Sodium and water retention takes place. Your liver will generate angiotensin and your kidney will start releasing renin, and this renin will help in this renin will activate something called as renin-angiotensin mechanism, thereby trying to produce severe vasoconstriction. The most potent vasoconstrictor in your body is renin. So renin-angiotensin mechanism gets activated, and then that particular vasoconstriction takes place to push your blood pressure up. But all this has got its own negativity. Why? Because the renal blood flow decreases, so does the adrenal blood flow, which will lead to decreased vasopressin, that is adrenaline and noradrenaline. So as this is happening, there is other types of things that is happening. Your kidneys start taking the damage, hypoxia as well as free radicals. So patient will go into something called as acute kidney injury, or ARF, previously called as acute renal failure, but it is not ARF. The term is not used anymore. It is acute kidney injury. And once AKI sets in, what are the other systems that are not taking blood now? Your splanchnic blood vasculature is compensating for the brain to function. So there is decreased blood supply to your intestines. So what's happening? Intestines will have mucosal hemorrhages with infarctions, patchy mucosal hemorrhage with infarction. When infarction is there anywhere, so what is happening? The intestines will start swelling, and this is because of edema, pooling of third space fluid. So edema occurs. As this is there, splanchnic blood as it is decreasing, what will happen? Your liver also is not getting adequate amount of blood. So what will it do? It will start releasing the liver enzymes initially, and if that is not compensated, it will further lead to jaundice failure, hepatic failure, which will lead to jaundice. So how many systems have now failed? 1, 2, 3. Then I already told musculoskeletal system also will stop taking blood. So what will happen? What is the musculoskeletal system? Here it is important because it's the musculoskeletal system that is going to produce RBCs. Yes. How? Because it is the single most important system for producing hemoglobin. I mean RBCs, that is your flat bones. So red bone marrow is failing. As the red bone marrow is failing, it will also fail the reticuloendothelial system, and thereby production of WBCs decreases, platelets also decreases. So how many systems have failed? 4 systems have failed, and this is called as multi-organ dysfunction. And once this happens, and the blood, this obnoxious or the abnormal stimuli is still not removed and the patient is bleeding, then comes the decreased blood to your brain. As the brain blood supply decreases, we are staring at irreversible shock and ultimately cell death. Your body is not able to get enough oxygen, it's not able to get enough nourishment, it is also not able to compensate anymore. So there are 4 stages of shock. Initially it is loss of blood, then a compensatory phase, then a decompensatory phase, and lastly an irreversible phase. Initially it's the blood loss, followed by a reversible state where your body will try to compensate, and then decompensated phase where your body is not in a state where it can compensate anymore, and ultimately irreversible state. When irreversible state comes into play, we are almost going to lose the patient. So first 4, 3, 8, whatever 6 hours is the most crucial time in correcting shock. By correcting adequately, we will be giving the best possible treatment. So once a patient comes to you, you're in the casualty as medical officer. Most of the times it's the casualty medical officer who first sees a patient of shock, more than the consultant, to speak frankly. So how will you identify a person with shock? You have to see all the following things. You have to see, number 1, pulse, number 2, blood pressure, number 3, the respiratory rate, number 4, the skin. The skin will be cold and clammy. The skin is cold and clammy. Patient is sweating. Patient is either confused or stuporous. If he's stuporous, you're dealing with more dangerous form of shock. And how do you see? You will see a dry tongue. He's dying, he's requesting for water. Capillary refilling time is decreased. Capillary refilling time is increased, not decreased, or increased. Because the blood is not there, venous return is not there, so it's taking a lot of time to refill. So capillary refilling time increases. And what are the other things that you're going to see? You have to see for the chest. So you just see all this, and then you have to come to a diagnosis, am I dealing with something dangerous? If you're dealing with something with dangerous, what you have to do? You have to immediately see if the patient's A, B, C, D. A is airway, B is breathing, C is circulation, and D is deformity. E is again you do a recheck all the systems what you have done before, because initially you want to save the patient. So you have checked, you saw that the patient is in shock. What do you do next? The most important thing you do is take a 14-16 gauge cannula, wide bore cannula, push it. You have to create 2 cannulas more likely. 14-16 are important because the blood transfusion also has to be done through 14 and 16. You cannot do it with a 20 number or 22 number because it's very small and the RBCs do not pass. So you have to create 2 lines, and 1 line you will start a bolus fluid about 500 ml in the in the first 1 hour, followed by 150 ml continuously the next. In the meanwhile, you have to take the samples, you have to take the blood samples, and send them to the lab. What are the blood sample investigations that you want to check? Most important. Do you want to check hemoglobin right now? No. You most probably will get a false positive or a false negative result if it's not 48 hours since the patient has lost blood. So you will probably get a false positive or false negative. Your estimate of blood loss is more important than trusting the hemoglobin, and at least in the initial 24 to 48 hours. No, we are not checking what is happening. The blood sample we are sending is to know the effects that are taking place. So you will send the patient sample for blood grouping and typing so that you can cross match and arrange for blood. Blood grouping and typing is the most important investigation in the shock initially, followed by the routine investigations of your hemogram, that is hemoglobin estimation, total count estimation, and then also the estimation of platelets. Initially, in the first 6 to 8 hours, you may not see any derangement. You have to repeat these after 24 hours. Because renal blood flow has decreased, blood urea serum creatinine also will probably increase, but that again is going to take after 24 hours. You may collect an LFT, but that also is more important after 24 to 48 hours. But initially, when you're dealing with the other investigation that you want to check is serum electrolytes, because there is an electrolyte imbalance that is going to take the sodium potassium pump is going to break down. Potassium is coming out of the cells, sodium is being retained in the body, so it is not good. So electrolytes are important. Electrolytes are important investigation that you will see. So once you have created a cannula, you have sent the patient's blood samples for the investigation. What is the next thing that you're going to do? How do you monitor this patient? The first and the single most important finding of any shock reversibility is urine output. So what is the normal urine output? Is 1 ml per hour per kg. So 1 ml per kg per hour is the normal urine output. So a healthy man of 60 kg weight will produce 60 ml urine per minute if he is healthy without any problems. In shock, this is going to decrease. So if you're giving fluid adequately, he has to start putting urine in the same amount. So you will monitor urine output. So the single most important thing during correction, the body gives the sign the body gives is increased urine output. And how do you check this? You put up the patient on a Foley's catheter. You put the patient on a Foley's catheter, and you will do this. After doing this, what is the thing that you're checking? The urine output is not coming down. The urine output is not coming up because the body is so badly dehydrated, a lot of loss of blood. So the next thing that you will check is central venous pressure, CVP or PCWP, capillary wedge pressure, PCWP. But amongst these two, the most important, CVP is no more the gold standard for checking the central venous pressure or central pressure, but it is the PCWP, capillary wedge pressure. This is the most important thing that you will do. You will create a right atrium directly, and then you check for the pressure. Normally it is 5 to 10 centimeters of water, not millimeters of mercury, it is centimeters of water, and anything below is worrisome to us. So you have to be monitoring. You have done this, still the patient is not able to do this. You have already given, you have started the patient with blood, and ideally what we should choose is, because the patient has lost lot of blood, he has lost lot of blood, and he's lost the plasma also. So we will need a plasma rich blood, that is whole blood. We will not be transfusing patient with PRBC. PRBC is important when you want to correct anemia rather than when you want to correct a hypovolemic shock. You have to give the patient with a whole blood, preferably fresh whole blood, so that the patient will improve. As you give the blood, if his pressures are increasing, you can be happy. But if the pressures are not increasing, whatever you're giving is losing. The patient is losing somewhere. So what do you have to do? You have to do two things. You may have to transfuse the patient with cryoprecipitate, or you may have to give the patient with fresh frozen plasma to arrest the bleeding. You still don't know. So then you will start doing the survey. You will do an ultrasound abdomen to see if there is any bleed. You will do an X-ray to see if there is a pelvic fracture. You will do the X-rays of multiple bones to see if any long bone has fractured, and that is causing bleeding. So you will do all this and then compensate. If the patient is bleeding more in the abdomen, you may have to send him for surgery. You may have to take the patient for surgery, ligate the vessel that is bleeding, and then you may have to do a damage control surgery, come out, and again start the patient with these measures like blood and all. And we want the mean arterial pressure to be at 65 millimeters of mercury. Mean arterial pressure to be at 65 millimeters of mercury. This is an entrance bit. And you should remember that when you're giving blood, if the blood pressure is not coming up, the next thing you do is you put the patient on inotropic support. Inotropic support is mostly in hypovolemic shock. It is epinephrine, norepinephrine. Norepinephrine is preferred. If these two fail, then we probably give vasopressin. We give vasopressin. The last resort we have, as inotrope is a vasopressin. It's very bad state if you're giving vasopressin. So you give vasopressin, and then again you monitor the urine output. If urine output is increasing, the mean arterial pressure is being maintained at greater than 65 millimeters of mercury, you can take a deep breath. But if it is not happening, then you have to investigate further. Why? Because in the compensatory mechanism, when you have all these happening, there is every chance that the endothelial injury takes place and platelets get aggregated. All the platelets are being utilized, and the blood gets the whole coagulation cascade changes, and there is an internal coagulation that taking place, that is called as disseminated intravascular coagulation. And once disseminated intravascular coagulation sets in, the chances of the patient's survival are minimal, and the chances of we losing that particular patient is quite high. So we want the person to have enough adequate blood supply. One of the problem with massive blood transfusion, if you're given 4 or 5 transfusions a day, it itself precipitates DIC. So we should be more careful. So you have to investigate. As you investigate, you will know. So once it is 24 to 48 hours, you have to check for serum creatinine blood urea, hemoglobin, liver function tests, serum electrolytes again, because all these end products are produced and potassium is raised. So with increased potassium, and then you will do a arterial blood gas analysis. You want to see whether there is compensatory oxygen that is taking place. If these all things are failing, then the ultimate thing is you will put the patient on ventilator. You will put the patient on mechanical ventilation to give his body enough perfusion with 100% oxygen concentration in the ventilatory support. So you have to put the patient in SNV mode, you have to check the patient, you have to try to improve, you have to give thermoregulators, you have to keep the patient warm, and you have to do everything possible. Probably at this part of time, with so many foreign blood and fluid entering, the chances that the patient is entering something called as septicemia or infection. To prevent infection, we may have to start on a broad spectrum antibiotic, and the drugs that we should be very careful and not giving is all ARBs and AC inhibitors, which will further which will cause damage to the kidney in acute kidney injury, though they are the drug of choices in chronic kidney disease. But in acute kidney injury, they will cause something called as efferent vasoconstriction, which will lead to further failure of the kidneys. So we don't want. And as you have done all these, if the patient is improving, you will see that his blood urea serum creatinine becoming normal, his urine output becoming normal, his mental status improving, his his feeling of hunger, and his capillary refilling time now becomes normal. If he is not improving, the chances are he is bleeding from every orifice because of DIC, disseminated intravascular coagulation. Is bleeding from every orifice, is not improving. He's become brain dead. And ultimately the patient, if he does not get better with all these mechanisms, is going to fail. If he's still going to fail, he may end up dying. If he improves, he'll improve. You may have to remove the mechanical ventilation if his blood pressure, if his mean arterial pressure is greater than 65 millimeters of mercury continuously, 24 to 48 hours. You can slowly taper the inotropic support and then wean it off. You may remove the central venous line for checking the PCWP. Then you have to cut down on the antibiotics, on the fluid. Once you remove the ventilator, you should ask the patient to take adequate. And you please remember, you cannot keep a patient on ventilator in intubation for more than 48 to 72 hours. Once it is called process 72 hours, you may have to create something called as a tracheostomy. And as this happens, if the patient has improved, it's well and good. Otherwise, most likely you would lose the patient if this does not happen in the 48 to 96 hours, most likely. So hypovolemic shock is really important. I hope you understood. Did anybody put any question? I'm just checking. Third semester, right? I have to go somewhere and then come. Second M.B.B.S regular batch. So everybody has understood everything. I have no questions. Is it? So, no question. Hypovolemic shock is fully understood. Still only 58 students. Very bad. It's okay. At least some of you are watching, and one of them is me, so that is 57. No one has any question? Okay, Chaturvedi has asked a question. Acute renal injury. What exactly you want to know in acute kidney injury? Okay, the whole process I'll try to cover it up. What happens is whenever your body has lost blood, whenever your body has lost lot of fluid in diarrhea, what happens is the first thing that your body says or your body thinks is the kidneys needs to stop taking blood. So there is renal blood flow decrease. As the renal blood flow decreases, as the renal blood flow decreases, your GFR decreases. If GFR is decreasing, what is happening? You are not putting adequate urine. But yes, this is a compensatory mechanism, but unfortunately it has its own negative. Your decreasing the renal blood flow will cause hypoxemia to the kidney. Okay, will cause hypoxemia to the kidney. As hypoxemia is set in, what will happen is your body will not have, your kidneys will stop or decrease its function. As it decreases its function, and hypoxia producing metabolites will cause damage to the kidneys. There is renal hypoperfusion. There is renal hypoperfusion. This hypoperfusion will lead to acute kidney failure. Basically, this is a reversible state. This is a reversible state. Once you correct the enough blood, you give the patient with enough blood fluid. As the blood supply to the kidney increases, your kidney will come back. Your kidney function will come back to normal. It won't be there. It's acute kidney injuries because of decreased renal blood flow, decreased GFR, and this decreased renal blood flow leading to hypoxemic kidney injury, that is called as tubular acidosis. This is very common phenomenon. Even a simple dehydration, please remember, even a simple dehydration will cause renal blood flow to decrease and decrease GFR, and this is called as pre-renal azotemia. This is called as pre-renal azotemia. Pre-renal azotemia or acute kidney injury is a 4-mark question in your final year. Okay. Yes, this is a very good question. Rajeshwari. Yes. Inotropic support, you have given adequate fluid. Okay, you have given adequate fluid and you have given enough amount of blood, and still the patient's blood pressure is not shooting up and it is continuously low blood pressure. The patient is in hypotension. That is when it is a signal that your body is giving that the inotropes, the body inotropes are not there, that is corticoids, corticosteroids and corticoids are not there, and you need to be compensating it. In hypovolemic shock, it is preferably that you give adrenaline, noradrenaline and vasopressin. So when you are giving in the initial 4 to 6 hours, you will understand whether this patient's blood pressure will shoot up or no. You have already given how much of fluid. I said a bolus of 500 ml in the first 1 hour, followed by about 150 to 200 ml. So that's about how much you would be giving. 200, 500, almost 3, 4, 5 liters of blood, and the blood pressure is not shooting up. It is not a good sign. So in the first 4 to 6 hours, you will decide whether the patient should be given on an inotropic support or no. Anything else? Nobody has any more questions? Yashwant is here. Yashwant, no question? Avinash? Who else? So you're all going to do excellent, is it? Because this is important for you even in second year, so it's better you ask the questions now. Okay, it is now clear that most of you, okay, so what is PCWP? It is capillary wedge pressure. Capillary wedge pressure is you're measuring the amount of your capillaries become collapsed and they start behaving haphazardly. Central venous pressure is you put a line through the internal jugular vein down and then you measure the central venous pressure, that is to the heart. But capillary wedge pressure is you will go through a peripheral line to understand what is happening with each of the capillaries down. This capillary wedge pressure, once they start acting properly, that is when the venous return is going to return. Central venous pressure will only measure what is happening in the heart, whereas in the PCWP you are going to measure the capillary wedge pressure. If it is improving, which means your veins are taking sufficient amount of blood and fluid, and then they are pushing the blood to the heart. That is why the capillary wedge pressure is far superior investigation investigation over your central venous pressure. PCWP is an important question. What happened? Yashwant Kumar Sharma said no. Any more question? CWP is capillary wedge pressure, PCWP is pulmonary capillary wedge pressure. You will insert directly into the lung. You will check the pressure of pressure of the capillaries in the venous system of the lung, and that is what gives you exactly idea how much venous return has come. So it is far superior to it's far superior to central venous pressure. Any more questions? Otherwise I'll move to the next cardiogenic shock. Okay, you're just telling that you are here with no sir, Ashwin, Avinash and Yashwant Sharma. Fine. So then we'll move to cardiogenic shock. Cardiogenic shock is exactly opposite to what is happening in hypovolemic shock. Still 12 minutes. I may not complete cardiogenic shock, but we'll try to cover the gist of it. Cardiogenic shock. When do you think cardiogenic shock? Basically in hypovolemic shock, it is because of the peripheral loss of blood, the heart is failing. Whereas in cardiogenic shock, it is happening at the heart and thereby failing the other systems of the body. So, when do you get a cardiogenic shock? When the patient has myocardial infarction, cardiac tamponade, pulmonary edema, CCF, that is congestive cardiac failure, and finally cardiac arrhythmias. When any of these things are there, your heart is failing. Okay, your heart is failing and thereby failing all the other structures. So when your heart fails, you will have everything. Your pulse is down, your blood pressure is down, your venous return, there will be no venous return at all because the heart itself is not pumping enough blood. So cardiogenic shock is important, and the drugs we give in cardiogenic shock is totally different from the drugs we give in in hypovolemic shock. In hypovolemic shock, I said noradrenaline is the drug of the choice, whereas in cardiogenic shock it is dobutamine. You give something called as dobutamine, the inotrope of choice. In cardiogenic shock, the heart fails. As the heart fails, your cardiac output decreases naturally. And as your cardiac output decreases, the tissue perfusion is going to decrease. Once the tissue perfusion decreases, all of the shock mechanism is just like the hypovolemic shock. But only thing is here, the heart, the central point has failed, not the peripheral system. The whole of it, again loss of again decreased blood supply to the kidney, that is called as cardiorenal syndrome. The change in this thing, the change in the nomenclature changes. So cardiorenal syndrome, the kidneys will start failing. Again heart is not functioning properly, so your splanchnic blood vessels and your skeletal-muscular system, all of them have now compensated, so they don't really function well. So in cardiogenic shock, you have to be more careful, you have to be extra careful. Why? Because if the cardiac muscle stops, you're not going to save the patient, so you should be extra careful. So immediately you take an ECG to see if the patient has gone into myocardial infarction. If he's gone into myocardial infarction, what do you do? If you see myocardial infarction, the patient has come to the casualty, a 45 male, obese, diabetic gentleman, maybe hypertensive, has come with dyspnea, has come with confusion because a lot of sweat, says retrosternal chest pain, and he's fully in a state of confusion. So when you see, you will take an ECG. Once you take the ECG, you are sure that either he is having arrhythmias, either he is in myocardial infarction. So whenever you see either of them, so what do? When initially you have to give heparin, but myocardial infarction, the patient is not near to a very good cardiac center, you will give heparin or low molecular weight heparin. You will give ecosprin about 350 milligrams, 75, that is 4 tablets of 75 milligrams will be 150, 300 milligrams of ecosprin, 75 mg of clopidogrel, 4 clopidogrel, again that is 300, 75 milligrams of clopidogrel. You will give an 80 milligrams of atorvastatin. If possible, if the patient is very near to a big center, cardiac center, you may not have to give low molecular weight heparin, because low molecular weight heparin will delay. Not many people are keen in taking up a patient who has been given with low molecular weight heparin for immediate angiogram and angioplasty. So you will have to wait. And here, if the heart is failing badly, if you see the features of CCF doing a 2D echo, you may have to do something called, if you do 2D echo and you see CCF, patient has gone into acute pulmonary edema because of myocardial infarction, you have to be careful. You can't be giving the patient any fluid. Fluid cannot be given. You have to give dopamine, dobutamine. The body has blood. The body has blood, but it is the heart that is not pumping. So you have to improve the cardiac function in a cardiogenic shock. So what you do is you give dobutamine, you put the patient on dobutamine and these supportive medications, adding a beta blocker if the blood pressure is very high, adding a beta blocker or AC inhibitor. These are the two cardioprotective antihypertensives that you can give in an emergency situation, and they have got a positive prognostic effect on a patient with myocardial infarction. That is beta blockers, AC inhibitors, and statins. 80 milligrams of statin, very good cardioselective beta blocker, that is Cardivas or Carvedilol, and then you give any AC inhibitor or ARB, telmisartan or Ranase, ACE inhibitors. You can give any Ramipril, you can give any of these, and the patient, you're giving enough time for the patient to survive. By giving low molecular weight heparin, you are doing anticoagulation. So little amount of clot that is there, that gets subdued, and there is a passage of blood, and then the patient will improve. If the patient has come to you with arrhythmias, if he's in ventricular arrhythmias, you give adenosine IV and followed by Cardarone. You give Cardarone. By giving beta blocker, you are helping the patient again with arrhythmias also. So cardiogenic shock, dobutamine is the inotrope of choice, and you will have to give a beta blocker if possibly. And then as the patient improves, we have to be more clear, and then send the patient to a cardiac center where he can get a stent done or probably an angiogram. And most of the times, if it's acute MI, 4 hours is the most crucial period. First 4 hours is the most crucial period. You can give the patient a 95% recovery. can give the patient a 95% recovery. And then there is something called as, in cardiogenic shock, I said cardiac tamponade. What happens is, when there is a damage to a vasculature of the heart, so the blood is leaking into the pericardium, and the pericardium is not allowing the heart to beat because of blood in it. So the patient will go into a compressive shock. The patient will go into a compressive shock. How do you treat? Nothing. You just have to do a pericardiocentesis using the 2D echo, and you may have to see what exactly has caused the damage. So you have to compensate it that way. Done. So if possible, the next class I'll be taking a septic shock, and the rest maybe we will not be dealing them in full detail like I did these two. Then we'll finish it off. Another class should be done. How about you all? Yashwant Kumar Sharma deleted his message. Did you understand, Rajarajeshwari, what is PCWP, pulmonary capillary wedge pressure? I have 5 minutes more. Can continue. I mean, I'm not going to start anything. I'll take questions. How is Gandhi? Gandhi, how is your dad? Oh, very nice. Nice to know, actually. Okay. Hope to see you all soon. And have a great time. I can't say have a great time, but at least stay home, stay safe. Thank you all. Bye. I'm stopping the streaming. Is it fine? Or anybody has any questions? I'm still ready to take. Done. Okay, it's 10:30. No, it's 1.5 minutes more. Any more question? So you're all very smart here. Nobody has any doubts. Fine. Have a great time. See you all soon.